So all of you can see the 3D anatomy now?
Yes, sir.
Okay. Okay, so let me start with the bone first. First with the dorsum of the foot, and then will be coming the medial aspect and the lateral aspect and the inferior aspect as well. So let me magnify a little bit. So few parts of the foot already covered in my last class during the ankle. So we'll be starting with the bones here. So we are having the tarsal bones. So what are the tarsal bones? On the top, we are having the talus. So this is your talus. After that, we are having calcaneum, which is articulating below. But talus is also articulating in front with this bone. What is this? Navicular bone. And calcaneum is articulating with the bone in front. What is that? That is your cuboid bone. So this is cuboid, this is navicular. Cuboid is articulating with the calcaneum and talus is articulating with navicular. So you see, these are calcaneum with cuboid, talus with navicular. So talus over on the top, but see, calcaneum is large and it is almost horizontal with that in that part. In that way, there is a gap here, and this gap is known as a sinus tarsi. So this is the articulation of the calcaneum and the talus is posterior part, but this part there is a gap. You see, this is a gap, and this gap is known as sinus tarsi, which is a reach of connective tissues, areolar tissues, and some of the nociceptors and mechanoreceptors are there. Now, this cuboid bone is directly articulating with the last two metatarsal bone, fourth and fifth. But the navicular bone, it is articulating with the three cuneiform bone, medial, then your intermediate, and then your lateral. So this cuneiform bone are articulating with the first metatarsal bone, second metatarsal bone, and third metatarsal bone. So cuboid is articulating with the two metatarsal bone, and three cuneiforms are articulating with the three metatarsal bone. So don't forget, what are the tarsal bones? This is talus just below the tibia, and then we are having the calcaneum. In front, we are having this is your navicular, and in front we are having in front of the talus we are having the three cuneiform bones: medial, intermediate, and lateral. And calcaneum, in front of the calcaneum, we are having the cuboid bone. So this cuboid bone is again articulating with last two metatarsal bone. And cuneiform bones, they are articulating with the three metatarsal bone, first, second, and third. Okay, so this is little bit of bony part. Now, little bit of ligamentous part. Let me add some ligaments. Not all, but at least few of the important ligaments which you should know. Few ligaments in the ankle already the covered, like the lateral ligament complex, medial ligament complex. So we are not going to cover those anymore. Just little bit. So this is the extensor reticulum. This is inferior extensor reticulum. There is another above, which is your superior extensor reticulum. This is your inferior extensor reticulum. This is a biciped divided on the lateral side. So I am just removing that. Let me put some tendons also. Then you will be able to understand it better. Okay. So one of the two ligaments here, let me show this ligament. This ligament is one of the very important ligament, dorsal calcaneo-cuboid ligament. And there is another ligament. Let me remove that. Otherwise, we will not be able to see that ligament. That is your bifurcate ligament. So bifurcate ligament is again, let me remove this. Bifurcate ligament is between the calcaneum. So this is bifurcate ligament. Bifurcate ligament has two parts. One part is with the calcaneum with the cuboid. So this is little bit of the lateral side. The dorsal calcaneo-cuboid ligament, this one is little on the lateral side, and bifurcate ligament has two limbs. One limb is calcaneum to the cuboid, another limb is calcaneum to the cuneiform. So these are the two ligaments we should know. Apart from the whatever the ligament we have discussed, particularly the ATFL we have discussed last day very elaborately, because ATFL is one of the commonest ligament that is getting injured there. So these are the ligaments on the dorsal side, you have to remember. And on the plantar surface, again, let me remove this plantar fascia. This is again very important. Plantar fasciopathy or plantar fasciitis is one of the very common pathological conditions. Already covered last class. So let me remove that. After that, we are having the different muscle layer. Let me go with the muscle layers on the plantar surface, and then we'll be talking about the ligaments. Ligaments will be automatically coming at the end. So this is there are three superficial layers. There are three important muscles. What are those three important muscles? On the most medial side, that means thumb, that means the great toe side, this is your abductor. And this is your, on the little toe side, this is also an abductor. So what will be, this abductor is attached with the great toe. So what will be the name of this abductor? Abductor hallucis. So this is your abductor hallucis. Because it is getting attached, it is abducting the great toe. And what will be the abductor of this side? Abductor digiti minimi. This is, it is going to the little toe. So the superficial layer on the either side, there are two abductor. One is abductor hallucis on the medial side. Another is abductor digiti minimi on the lateral side. So let me remove these two abductor. And another in between these two abductor, this muscle is your flexor. Flexor digitorum brevis. Flexor digitorum brevis. It is getting attached to the four toes, not for the great toe, because great toe has its different flexor digitorum brevis. Flexor, not digitorum, flexor hallucis brevis. There is a different, this one. This is your flexor hallucis brevis. So it don't have, only the four leaves are there. So not the fifth one is not there. So, but this flexor hallucis brevis is little deeper. So superficially, three muscles. What are those three muscles? On the medial side or great toe side, we are having the abductor hallucis. On the lateral side or the fifth toe side, lateral side, we are having the abductor digiti minimi. And in the middle, we are having the flexor digitorum brevis. So these are the three superficial muscles. Let us remove all those three. Then what will come? Then few muscles will come. On the heel side, we are having these muscles. That is your quadratus plantae. Quadratus plantae, these muscles. These muscles is getting attached to the calcaneum, but again inserted over this tendon. What is this tendon? This is your flexor digitorum longus. Flexor digitorum longus, it is going to flex the fingers, toes, and it is getting attached with that. So in this layer, what are the muscles we are having? One is your quadratus plantae. Next one is, let me remove that. Then next is the flexor digitorum longus. So flexor digitorum longus is coming through the ankle. Already we have learned that. So Tom, Dick, Harry, anterior to posterior. After the tibialis posterior was having the flexor digitorum longus. So that flexor digitorum longus, we are having the, like in the palm, we have understood that there are the lumbricals muscles. Here also we are having the lumbricals muscles. So these lumbricals muscles are basically originating from this flexor digitorum longus tendons and getting attached where? At the base of the phalanx, proximal phalanx. It causes the flexion, like in the palm. It causes the flexion of the metatarsophalangeal joints. So these are like worm, like, the muscles, small muscles getting originated from the tendons. So these are the lumbrical muscle. So now here, another thing we have to understand and we have to remember. So I'm going back in the ankle part, and then we'll be coming back to here. Let me go little in the ankle. So the ankle, you remember the mnemonics? What was there? Tom, Dick, Harry. So Tom, this was Tom, tibialis posterior. Then Dick, digitorum, flexor digitorum, and this was Harry. So now we see the flexor hallucis longus, this one. Flexor hallucis longus is most posterior muscle in the ankle. And it is going straight towards the, the base of the distal phalanx. And here is your flexor digitorum, and they are crossing this area. So this crossing area, there can be the frictions of these tendons and cause some tendinopathies there. And this area is known as the knot of Henry. Knot of Henry. So what is knot of Henry? Knot of Henry is where the flexor digitorum longus and flexor hallucis longus are crossing. So in the tarsal tunnel, flexor hallucis longus was the most posterior tendon. But here it will be coming most medial again. And this will be going, flexor digitorum will be going laterally. So they'll be crossing. So this crossing area is known as the knot of Henry. So this was the second layer muscles. Let us remove these muscles. Quadratus plantae already we have removed. And then we removed the flexor digitorum, and then lumbricals also. Let me remove lumbricals. And let me remove this one also. This was your flexor hallucis longus. So now few tendons are come. What are those few tendons? So these are the now flexor hallucis brevis. You remember, for the flexor digitorum brevis, there was the most superficial. In between the two abductor, we was having the flexor digitorum. But flexor hallucis, for the great toe, we are having a different, a strong, only dedicated to the great toe, that is your flexor hallucis brevis. So flexor hallucis brevis has basically the two limb, lateral and the medial. Medial is getting originated from the tendon sheath of the tibialis posterior tendon. So it is getting attached to the tibialis posterior tendon, and the medial head is going down towards the base. So this is the flexor tendon at this level, and there is an adductor tendon. Adductor for the hallucis. So adductor again, it is having the two head. This is your oblique head, and this is your transverse head. So in this layer, we are having these muscles and another muscles here, like you are having the flexor hallucis brevis. So here there is another flexor, flexor digiti minimi. So for the great toe, we are having the flexor, the hallucis brevis, and here it is having the flexor digiti minimi. So this is on this side. So let us hide all these muscles in this layer. The third layer. Let us remove these muscles. And then what will be muscles will be getting? We'll be getting the, what are this? Interosseous. Plantar interosseous. These are the plantar interosseous. And then little more deeper is the dorsal interosseous. So remember, the plantar interosseous are the adductors, and the dorsal interosseous are abductors of the toes. So, little bit complicated, but still, some of the things you have to remember. And if you are having the 3D anatomy picture, you can go through again and again, and you can, master it. So now few ligaments are exposed. What are these ligaments? This ligament is the long plantar ligament. So this long plantar ligament is from the calcaneum, and then going over the cuboid bone. This is the cuboid bone, and then going to the base of the metatarsal bones. And if you are removing the long plantar, then you'll be having the short plantar ligament. This is short plantar ligament, but also known as the calcaneo-cuboid plantar side. We have seen the dorsal side, dorsal calcaneo-cuboid ligament, and this is plantar calcaneo-cuboid ligament, and this is also known as the short plantar ligament. Superficially long plantar, and deep is your short plantar ligament. And another thing is this tendon also you have to remember. This tendon is the fibularis longus or peroneus longus. So the peroneus longus and brevis, two tendons was remembering. Brevis was near to the bone, to the lateral malleolus, and longus was the tendinous. So that longus tendinous goes to this tunnel and goes to get attached at the base of the first metatarsal bone. Okay, so this was your plantar surface. Now let me go to the dorsal surface. Medial, already we have learned some of these things, but but few of the things you can remember. This was the tibialis anterior tendon. Tibialis anterior tendon, where it gets attached? It gets attached, little bit fibers get attached into the, what is this bone? This bone is navicular and base of the great toe. So here it is at the attachment of your tibialis anterior. And tibialis posterior, You see, tibialis posterior heart is attached. So it gets attached to the in a fan-shaped manner to the little bit of in the head of the first, second, third metatarsal bones, and little bit also inserted into the navicular bone. So this is your tibialis. This is your tibialis posterior. So these are the on the medial side. Now let me come to the dorsal side. In the dorsal side, let me put the tendons. So dorsal side, you can remember in here, the mnemonics was Tom, Dick, Harry. Tibialis posterior, flexor digitorum longus, and flexor hallucis longus, and they cross over this area is known as the knot of Henry. Anteriorly, it is the opposite. Tom, Harry, Dick. Tom, Harry, Dick means first one is tibialis anterior. After that, extensor hallucis. After that, extensor digitorum. But again, extensor digitorum, the last tendon, this is not extensor digitorum part. This is your peroneus tarsi. But they are in the same, your tendon sheath. Same tendon sheath, you know, the lateral most part, which is mostly the muscular part at this ankle part. So that goes as a peroneus tarsus, which goes to the base of the fifth metatarsal bone. And others are the extensor tendons, the four lips of the extensor tendons here. And below the extensor tendons, we are having the extensor brevis. So extensor digitorum brevis muscles. And on the medial side, we are having the another extensor muscles, that is your extensor hallucis brevis, which is going to the great toe. So dorsum of the foot, what are the muscles and tendon? It is little less complicated than the plantar surface. So dorsal surface, we are having the Tom, Harry, Dick, tibialis anterior, hallucis, extensor hallucis longus, extensor digitorum, and in the same tendon compartments, we are having another tendon, that is your peroneus tarsus. And below all these extensor tendons, we are having the extensor digitorum brevis and extensor hallucis brevis. So these are the on the dorsal side. And few more on the lateral side. One was, you have already discussed this ligament, that is your the dorsal calcaneo-cuboid ligament. And another important things in this area is your subtalar joint injection. So subtalar, let me increase the, so subtalar joint injection is where to go. Let me remove the, okay. So this was your lateral malleolus. This was your, the talus. This was your calcaneum. Subtalar joint means this joint, but not here. This is the sinus tarsi. This is not the joint, part of the joint. So you have to come here, or sometimes we come here, the posterior part. If you are holding the probe here, we'll be getting this talus, the tibia, talus, calcaneum. We can inject in this area, or we can go to the lateral side. Over the lateral malleolus, we can talus and the cuboid. This is the injections. So subtalar injection is one of the important area in the ankle arthritis. The either tibiotalar or the subtalar joint might be involved, and based on that, we can go for the intraarticular injections thing. Okay, so anything you wish to repeat in the ankle part, 3D anatomy? Now I'll be going to the face 3D anatomy. If anyone wishes me to show me any of the structures again, I can repeat it, because, you know, unless we are having the good knowledge about the anatomy, we cannot learn the stone anatomy. Nothing? Okay, then let me go to the face. So here will be few of the, you know, very, very important is few of the small knobs, which is our target, and it is one of the common target for us. So first is your, let me increase it further. First is your maxillary and mandibular. So for the maxillary and mandibular, so you can see this fossa. This fossa is known as the pterygopalatine fossa. So this pterygopalatine fossa is your very important for us. So this is the area through which you can go for the injection of the sphenopalatine, also called the sphenopalatine fossa. Sphenopalatine fossa and pterygopalatine fossa are the same. And this is the condyle, this is your coronoid. So this is the area which is obstructing this path. So if you are opening your mouth, then this area will be little bit more exposed. Here I cannot open the mouth, but this is the area which is our target. And we can see this is your lateral, this is the sphenoid bone. This is the lateral pterygoid plate. So this, if we are going into this anterior to this plate, then we'll be going for the mandibular nerve injection. And if you're going posterior to this, we'll be doing the mandibular nerve injections. Another is your sphenopalatine ganglion is situated here, but ultrasound guided sphenopalatine ganglion block is not a standard procedures. So, but still the injection procedures are almost same. If you wish to go for the mandibular nerve injection, you have to go to the uppermost part of the foramen. So let me put the nerve, then you can understand have some idea about where the nerve is. So let me put the nerves there. So the mandibular nerve, let me remove this maxilla. So this was the sphenoid bone, the lateral pterygoid plate. And here, this nerve is not that one, that one is your maxillary nerve. So after that, it is getting divided. This is the continuation of the maxillary nerve. This nerve, the infraorbital nerve, that is continuation of the maxillary nerve. So if you wish to go for the maxillary nerve block, you have to identify this bone. And if you are going anterior to that, we'll be going for that. And if you are going to block your mandibular nerve, so here is the maxillary nerve which is getting divided here. So if you have to go posterior to that. So by that way, we can do the maxillary and the mandibular nerve block. Apart from that, few other nerves is our target. One of them is this is supraorbital and supratrochlear. Supraorbital nerve is more medial than the supraorbital. But supraorbital nerve is easy because there is a foramen there. When we'll be holding the probe here, we'll be getting a break. And sometimes blood vessels are accompanying, and you can identify this nicely. Nerve may not be able, you will not be able to identify the nerve because it is a very tiny nerve, but you'll be able to identify the break, the cortical break, the foramen. And sometimes you'll be getting the blood vessels there. So that is how we have to identify the supraorbital, and medially is the supratrochlear. The infraorbital is much easier because this foramen is much bigger. So there are different techniques. What is our technique? I'll be showing that. That is very easy. We'll be holding the probe like this, and we'll be able to see these hood-like things and the foramen approach here. And then we'll be discussing the mandibular. Again, the mandibular, there is mental. Mental will be having the foramen, and we may or may not identify some blood vessels there. And you have to identify the break, and you have to inject here. So these are the three. Okay, another I forgot to, let me put the blood vessels as well. Artery. Okay, so in the mental, there is a blood vessels, you see, tiny blood vessels. Here also the tiny blood vessels, here also tiny blood vessels accompanies the nerve. So mostly we identify the blood vessels to identify the nerve. And another is your auriculotemporal nerve. So this is your temporal artery, superficial temporal artery, which accompanies this nerve. This is your auriculotemporal nerve. This is also another nerve in the face, which sometimes we do the block. Other nerve in the posterior to the tragus, we'll be discussing when we'll be discussing the neck, the occipital, greater occipital, lesser occipital, third occipital. So we'll be discussing in the next class, neck class. So today we'll be discussing these 4-5 nerves. One is maxillary mandibular here, the main trunk. Then is your auriculotemporal here. Then the supraorbital, infraorbital, and mental. Okay, any questions? No questions?
So what about the trigeminal?
Trigeminal under the ultrasound guidance is very difficult. So it is the standard procedure is your fluoroscopy guided. Okay?
Okay, sir.
Anything else you wish to see? Repeat. Anything else in the 3D anatomy? Okay, so now let me prepare one of the things you remember, I was actually asking my volunteer, have you, soaken your foot with the water? Because one of the difficulty in the foot, whatever is the volunteer. So normally the foot sole skin is very thick and it's dry most of the times. So it's very difficult to penetrate the ultrasound beam, and most of the times you will not be able to see it very nicely. And you have to increase the gain maximum to see the foot structures. So here also in our volunteer also the same difficulties are there, but we have soaked it, and let me see how much is it visible.
So, do we need to identify the muscles of the face for to go for the blocks of the nerve?
No. It's mostly the bony landmark. So the bony landmark is did not identify each of the small muscles. All these knobs, whatever I told you, for the maxillary and mandibular, you need to identify the lateral pterygoid plate of the sphenoid bone, and the supraorbital you have to identify the break in the bone. Infraorbital also, the mental also. So all these, and you have to identify the blood vessels accompanying it.
And so, in case of pain, not only superficial but including the muscle and the internal structures of the oral cavity, do we need to identify what nerves are involved in which type of pain?
Based on the anatomical locations, you have to identify. Like say, for example, in the face, what are the sensory nerves? Mostly it is supplied by the trigeminal. So you have to know that which division of the trigeminal. So the three main divisions. Above the orbit, we are having the ophthalmic division, then the orbit and the lip. So we are having in between these two, we are having the maxillary, and then below is a mandibular. And mouth cavity also, mostly it is the maxillary division. Some is by the little bit by the mandibular division, but mostly the maxillary division. And the posterior part of the tongue and your throat is supplied by the glossopharyngeal. And in the skin area also, below the tragus, we are having the occipital nerve, greater occipital, and the lesser occipital, sorry, and the greater occipital nerve. A small area here is supplied by, in this area is posterior, is by the glossopharyngeal, and other branches of the superficial cervical plexus, which is supplied this area. Okay, so by identifying the territory, you have to understand that which nerve might be involved in this pain and which nerves you need to target.
Thank you, sir.
Okay, let me start with the plantar area. Okay, just give me some time. Having some problem.
Sir, this is not Sanjeev Das food.
This is not Sanjeev Das foot. Yes, Sanjeev Das sole is much thicker. So almost nothing is visible. So this is the sole of a younger lady to have a thinner sole so that we can see the plantar surface nicely. Okay.
Yes, sir.
Okay. So you identified that this is not Sanjeev Das foot.
Yes, sir.
Okay. So first, the camera পিছনে দাঁড়িয়ে থাক. So we are taking a high frequency linear probe with the frequency bandwidth of 4 to 20 megahertz. And depth I'll be controlling as and when needed. So first, let us find out the most important target. Very frequently we are doing. So let me, as I was telling, we need to increase the gain, otherwise it is difficult. Okay, so what can I see here? So this was the calcaneum. Okay, let me draw it. So calcaneum, and this is your plantar fascia. The tool in between these two. So when you wish to see what is the thickness, normally we see the thickness here. And if it is more than 4, then we are telling that this is a abnormal things. So this is your fat pad. So this fat pad is most thick towards the sole. And this fat pad will be gradually thinner when you'll be going more distally towards your metatarsal area. And then you can see the two muscles there. And if you can remember, what are the two muscles there? The most in the middle, the topmost layer, first layer muscle, what was the name of that? So we discussed about the 3 muscles. On the medial side, abductor hallucis. On the lateral side, abductor minimi. And in the middle, what was there? Flexor digitorum brevis. Flexor digitorum brevis. So this muscle is flexor digitorum brevis. And this another muscle there is there. What is that? Below that, quadratus plantar. Okay, understood?
Yes, sir.
Okay, so let me show you again. So I was here. I hope everybody can see how I am holding the probe. Let me give you a closer view. So here was my calcaneum, and there are 2 distinct layers of the muscles. You can see what I was telling. I'm focusing the plantar fascia. So plantar fascia, if I'm going more distally, see what is happening? It is coming more superficial. So fat layer is most thick towards the heel side. And you can see the 2 muscle layer there. So middle one is the superficial one. Below the plantar fascia is your flexor digitorum brevis. Below that, quadratus plantar. And if we are going here, let me fix it here. So you can see the calcaneum taking a dip here, and there is a break. This is your calcaneo-cuboid joint, and then cuboid is like this. And here you can see one tendon. What is that tendon? This is your peroneus longus tendon. As I told, peroneus longus tendon comes like this, and it comes like this, and it's get attached to the base of the great toe. So this is it is the short axis of this tendon, and this is the area of the, again I'm so here is the calcaneo-cuboid joint. The cuboid is at this separate. Cuboid at here, it is like this, and it is hosting one tendon, that is your peroneus longus tendon. So now here you can see few ligaments. This ligament is your short, plantar ligament. Another name was your plantar calcaneo-cuboid ligament is also known as the short plantar ligament. And long plantar ligament is where? Long plantar ligament is going like this and going over the cuboid, going to get attached to the base of the metatarsal. So this ligament is your long plantar ligament and this was your short plantar ligament. Okay. So let me clear it and let me show you again. Let me put a lot of gel. So I'm here, I was here. So I was looking at this plantar fascia, and I'm going distally. So I was here. So this was your cuboid bone. This was your calcaneocuboid. Calcaneum is like this. Calcaneocuboid joint. This is your short plantar ligament or plantar calcaneocuboid ligament. And this is your long plantar ligament from calcaneum to the base of the metatarsal. Okay. So apart from that, if I am coming medially, so this is the plantar fascia, and if I am coming more medially, so what will you see? So here, and look, see how I am holding the probe. I am holding the probe little bit of oblique direction. So what muscles will be seen? So this is one muscle. This is your abductor hallucis. And this is another muscle, which is your
That's
quad.
a digital.
And here we will be able to see the nerves, neurovascular layer, this area. And here, what will be seeing? You'll be seeing the Baxter nerve here. You'll be seeing the lateral plantar. Basically, Baxter nerve is a branch from the lateral plantar and the medial plantar here. I'm just trying to focus those two nerves. In between these two layers of the muscle, this is your abductor hallucis, and this was your quadratus plantar. Clear? So let me show you again. So I'm here on the medial side, and as I was telling, so here you can see the two layers of the muscles, and in between the two layers, so we are having the neurovascular bundles. You can see let me focus the Baxter nerve very nicely, and then so this is your Baxter nerve. I'm just tilting so that you'll be able to understand this is your Baxter nerve. And these are the two other nerves. One nerve, lateral plantar, and this is the medial plantar. And this muscle is your quadratus plantar. This muscle is the abductor hallucis. So now just follow these nerves. And if I'm going more towards your now abductor hallucis is getting okay. So I am in the tarsal tunnel now. And this is the tibial nerve getting divided. If I'm going more above, here is your tibial nerve. Okay. So the tibial nerve, this is the blood vessel, the tibial nerve, follow that. It is getting divided. Tibial nerve is getting divided. Remember the three branch initially. What was the three branch? The medial calcaneal, lateral plantar, and medial plantar. And then if I'm going down, so these nerves are getting divided. And now another branch which is appearing is your Baxter nerve or inferior calcaneal branch of the lateral plantar nerves. And follow these nerves, follow this branch of the nerves. I'm coming down, and now it will be now the quadratus plantar muscles has started appearing, and also abductor hallucis has started appearing. And in these, this is one nerve, lateral plantar, medial plantar, and here is the Baxter nerve. And here, this is your quadratus plantar. And this is your abductor hallucis. Okay, so now let us see the knot of hand. So here, if I'm holding my probe here, so let us identify these tendons. One is your tibialis posterior tendon. So in the middle of the screen is my This is your tibialis posterior. Let us see first tibialis posterior. So I'm now tilting it, making it long axis. So you can see the tibialis posterior tendon. This is the tibialis posterior tendon. And you see where it is coming. It is dipping down. It is dipping down and getting attached. Some part is getting attached to the. Okay, so this is the tibialis. Tibialis posterior. So getting attached the base of the toes. Metatarsal bone, sorry. Now look at the second one. Tom, Dick. Dick means flexor digitorum. So this was your flexor digitorum, and here was your the flexor hallucis. So initially this is more anterior, this is posterior. Now when I'll be in the long axis, when I'll be seeing this tendon, so this look at following this tendon. This is your the flexor digitorum, and you see when I'm coming here, this is the flexor digitorum. So when I'm coming here, I can see the both the tendons together. So flexor digitorum and the flexor hallucis. So one and one. And here is your knot of the Henry. When you are coming here, you see the two tendon. Here is your knot of Henry. So one tendon is going crossing over, another tendon is remaining below. So these are the two tendons. I'm just tilting the probe. You see, try to identify the two tendons nicely. The two tendons nicely. One is going more anterior, one is going medial, and another is going lateral. So this area is your knot of Henry, where there might be some frictions and there might be. So this is the tendon going like this. And this is the tendon going like this. Okay, so now if you are following the flexor hallucis, you see, then you put some gel. Flexor hallucis longus. So this was the flexor hallucis longus. Flexor hallucis longus. So here it will be between the two sesamoid bone. Let me reduce the depth a little bit. Oh. So this was the, let me draw. So this was one sesamoid, medial side. This is lateral side. This is the flexor hallucis longus tendon. So normally there are two ligaments like this, and which is binding and holding the flexor hallucis longus tendon. So sometimes there is inflammations and it can cause the pain. Now, let me come here, few other in the plantar surface. So here, if I am holding the probe, like if you can remember the, let me increase the depth again. Okay, so if you can remember the tendons again, after the flexor digitorum brevis in the middle, I am holding it in the middle. So after that, what will be there? Which is there in the second layer? Second layer was flexor digitorum longus. After the flexor digitorum brevis. So this part is your flexor digitorum brevis. So let me take this view. So this is your flexor digitorum brevis. After that, you can see the tendons of the, these are the tendons of the flexor digitorum longus. And in between these black areas, like you have seen in the hand, these are the lumbricals. So these are the lumbricals muscles. After that layer, which muscles we are having? We are having the adductor muscles. Adductor and the flexor muscles. If you are going more towards this side, you will be having the flexor muscles. This is the flexor muscles, two head of the flexor muscles. And here is your adductor muscles. I'm holding this. So this is the horizontal part of the your adductor muscles. And if you're tilting the probe in this way, below the lumbricals and the flexor digitorum, this is the oblique part of the adductor. As you can remember, adductor has the two part, and those muscles are below the flexor digitorum. So flexor digitorum and lumbricals. So this is the oblique part, and if I'm holding in a horizontal way, so this is the horizontal part. And after that, we are having the plantar and the dorsal interciliary muscles. And now I'll be going to another very important area, that is the Morton's neuromyelitis. So I'm coming more towards the distal part of the metatarsal bone. So now, if my middle of my probe is, you can see the digital vessels and the nerves. So in between, the nerves are not always very nicely seen. So just in the middle of the screen, you can see the pulsating blood vessels and hyperechoic, hypoechoic things. That is your nerve. You can see the nerve nicely. This is your nerve. And pulsating blood vessels. Let me put the color there. So the hyperechoic structure is your nerve. So the nerve is, because this is the thickest nerve amongst all the digital nerves. This is the thickest nerve. So that is the reason why this nerve is better seen than the other. Other nerves are not, that digital nerves are not seen, except this one. The plantar digital nerves, these plantar digital nerves are better seen. So this is the area for your motor skill. So this is the plantar surface, plantar and the medial surface. Now I'll be going to the dorsal surface, dorsum of the foot. So in the dorsum of the foot, you remember what was the tendons there? Most medially, we was having the tibialis posterior. So now here, this is your tibialis posterior. Tibialis posterior, just in the center of my screen, this is your tibialis posterior. And you can remember the tibialis posterior, how it is getting attached. It is getting attached in the cuneiform and the little bit on the base of the first metatarsal bone. So this was this. Okay, let me draw this muscles again. Okay, so this was my tendinous. Some part is your tendinous, because I am holding the probe little above. So this is your tibialis anterior. And then we are having the extensor hallucis. Here you have to mnemonics was opposite, Tom Harridick. And this was the common sheath for the peroneal start side and the extensor digital. And here was your blood vessels, here was your nerve. So let me put it again. So my aspect marker is on the lateral side. Aspect marker is on the lateral side, and let me reduce the depth so that you will be able to appreciate it better. Okay, so you can see the pulsating blood vessels there. This was your tibialis anterior. This was the flexor. How to understand that? You just move the, see what I'm doing? I'm moving the great toe. So it is moving. So that is your extensor hallucis longus. And if I'm coming here, this was your peroneal tarsal, and this was your extensor digitorum together in the same sheath, same tendinous sheath. Now follow this tendon if I am going more distally. Sorry. So first let me follow one by one. This was your tibialis anterior. Follow that. Tibialis anterior. Now it is becoming tendinous. Now it is becoming fully tendinous. And now it is getting attached. If I'm looking in the long axis, sorry. So this was your tibialis anterior. Now it is getting tendinous. And now it is getting attached, going down and getting attached. Now flexor hallucis, easy to understand that. Okay, if I'm doing the movement there, then first let me see in the, so this was, let me see in the long axis. You can see the movement with the movement of the great toe. So the talus, then your cuneiform, navicular and then cuneiform. So this is how is getting okay. So this was your flexor analysis. And then if I'm going more laterally, now again I am showing in short axis. So here so below the extensor tendons. So these are the extensor tendons. This is your extensor longus and peroneus tarsus. So this is your the extensor digitorum brevis, and this was your extensor hallucis brevis. Again, let me put it here. So the below muscles here, I'm a little bit above. If I'm coming down. So this part was your peroneus tarsus. This part was your extensor digitorum. This was your extensor hallucis, and if I'm coming, this was your the tibialis anterior. Now, if I'm coming down, see what is happening. Talus bone. So peroneus tarsus, extensor digitorum, and extensor hallucis. And now, if I'm coming down, so now these are the muscles. These are the extensor brevis muscles and extensor hallucis muscles. Extensor digitorum brevis and extensor hallucis. And you see, this was the tendon on the top is your extensor digitorum and extensor digitorum longus. And these are the tendon which will be growing on this side. See how they are slipping and going towards the from the lateral to medial side. If I'm slipping the up and down, you see the extensor brevis tendons below the extensor digitorum tendons are here. These are the extensor digitorum tendons and peroneus tarsi tendons. And this extensor brevis tendons is gliding and moving toward from the medial to the lateral side. You have seen on the 3D anatomy, these muscles are from the lateral to the medial side. Okay, and also already you have seen the nerve there. So just this was here, the deep peroneal nerve. Superficial peroneal nerve also you can see here. Superficial peroneal nerve is, this is your superficial peroneal nerve. So superficial peroneal nerve is, this was your reticulum which is getting divided. So this nerve is above the reticulum, whereas this nerve is below the reticulum. This is your the superficial peroneal, and this was your deep peroneal. Okay, so up to this much for the foot. If you want to see anything again, I can show you. Otherwise, I'll be going to the face. Sure. ক্যামেরাটা মুখে পাস করে যে কোনো একটা দিকে মুখটা পাস আর আমার দিকে okay, so first I'll be taking a curvilinear probe because to see the mandibular and maxillary we need to see the need to take the curvilinear probe. And I need to increase the depth also. Okay, so here, if I'm holding the probe here, sorry, I have not changed the probe. So here, one important bone is, let me decrease the depth a little bit. So here, this is a bone. This is a bone. What is that bone? That is your zygomatic arch. And if I'm coming down, let me increase the depth a little bit. So here, this is your condyle. Why this is condyle? Because you can see the acoustic saddle there. Condyle of the here you can see that in the mandible, we are having the two bony part. One is your condyle, another is your coronoid. So this is your coronoid process. This is your condyle. So in between the coronoid and the condyle, this is the mandibular notch, and through which we have to look for. And this is your pterygoid plate. Okay, so the few muscles are there. One is your on the superficial is the masseter muscles. Here is your the temporalis muscles, and here is your pterygoid muscles. And this is your the pterygoid plate. Anterior to that, if you are moving, if I am injecting here, it will be your maxillary nerve block. And if you are, I'm just trying to focus it a little bit better. So keep the mouth open, and through that, so that your space, this space will be increasing a little bit, nicely visible, and you look for the, this is your pterygoid plate. So just pterygoid plate anterior, if you are coming like this, you are going to inject the maxillary nerve, and if you are coming like this, you are going to give the maxillary nerve, mandibular nerve. Okay, so you have to identify the coronoid process. In between, posterior to the coronoid process, you will be getting this acoustic window. This acoustic window, you have to look for this pterygoid plate. Anterior to the pterygoid plate is your maxillary. Posterior to the pterygoid plate is your mandible. Okay, is it clear? And normally artery accompanies. If I'm giving the color, you can see the the blood vessels also. So this is the tape. This blood vessel is important, not the superficial one. Below, the blue one, which is pulsating. That is basically for the maxillary, accompanying the maxillary nerve. Okay, now I'll be taking the linear probe for the other superficial nerve of the face. So here I'm putting my probe. Okay, let me change my probe. Let me reduce the depth. Okay, so this was your zygoma. And if I'm coming posteriorly towards the tragus, I'll be getting the pulsations. And just beside that pulsations, you can find out the nerve. You can see the pulsations. This one. So just posterior to that, this is your nerve. Which nerve? Auriculotemporal nerve. This one. Auriculotemporal nerve. So what is the trick? I'm holding the probe over the zygoma. I'm searching for the blood vessels just in front of the tragus. And when you're seeing the blood vessels, just beside that, it can be sometimes anterior, sometimes posterior. To that is your nerve. So this is your auriculotemporal nerve. Okay. So now So now we are so first is your supraorbital. Supraorbital will be holding the probe over the eyebrow and will be searching. So my aspect marker is towards the lateral side. Aspect marker is towards the lateral side. Let me decrease the depth further. And I'm holding the probe where? I'm holding the probe over the eyebrow, and I'm coming down to see the break. You see the break here? And there you can put the color. So you can see that the color, the break and the color. Not this one. I'm just freezing it. So not this one, what I was telling, not this one. There was another pulse, this break, there is another pulsation pulse here. So just beside that is your nerve. So look at this break. Sometimes blood vessels are not visible, so tiny, but blood vessels on the color may not pick up, but you will be able to see the, the break. That is more important. So you see, this is the bony cortex, and you just come down, and you look for the break. When you are looking for the break, so on the center of the screen, you can see the small tiny blood vessels in the break. So that is the area. So this is the area for the supra orbital. You can see here some small tiny pulses there. So my center of the screen, the color what is taken, that is the blood vessel. That is the area. Exactly in the center of this box. So here I was seeing some pulsations. So that was the area for the supraorbital. Supratrochlear will be a little bit more medium, and it is not accompanied by any blood vessels. So now the intraorbital. Intraorbital, there are different techniques. So what technique we follow is we hold the probe longitudinally. My aspect marker is now cranial side, towards the face side. So here I am holding, see how I am holding the probe, and on the product. So now here, this is the base of the orbit. Let me draw. So this is the base of the orbit. This is the break, where you can see the pulsations there. I'll be just putting the color. So this is the area. This is the area where you have to search for. You see now the very nice pulsation. So that is the area where, and you can see this is the foramen. You can see the foramen also very nicely. So let me feed it here. Okay. So which one? So what was this was your base of the orbit. So this was the bone, and here you can see the pulsations. So that is for the intraorbital. So how do you do? Needle comes from like this, and we do the procedure. All this procedure, supraorbital, intraorbital, mental, all these procedure videos are there in our YouTube channel. So you can go through and you can see those the nerve blocks under ultrasound guidance. Okay, now is your mental. For the mental, so again, I'll be searching for the break. You can see the break there, and most of the times you can see the break. And again, you might be getting the color there. Sometimes it is difficult, but break is very nicely visible. So in the center of my screen, the break, that is the, so this is the area for the mental nerve. So here, the needle comes like that and inject here. And again, this video is also there under the ultrasound guidance. So you can go through that. And these nerve blocks are very useful. One of the very commonly done procedure. And you should learn this nicely. And it is easy also, not that difficult. Okay. Thank you very much.
Sir, foramen oval, is it easy to find it by ultrasound?
Pardon?
Foramen oval.
Foramen oval is difficult to see under the ultrasound. That is done by the your standard technique. I already told you the gastrin ganglion block standard technique is to do by your serum. Some articles are there in between the maxilla and mandible, but that is not the standard technique, and we don't follow it. Foramen oval, we always do it under the CM guidance. Okay.
Okay. Sir, another question. What's the difference between Gasserian block and sphenopalatine block?
It is completely different. Gastrin ganglion block is done through the foramen oval, and sphenopalatine ganglion is block, whatever I have shown for the maxillary, almost similar. Though again, sphenopalatine ganglion block is again better done under the CM guidance, not by the ultrasound guidance. But still, it can be done. What I have shown is the maxillary nerve block. The same thing in the sphenopalatine fossa. If you are coming a little bit of inferior, then you are going to have the. Okay, let me show you the 3D anatomy so that you can. Okay, first of all, if you wish to show anything, otherwise I am stopping it and I am just explaining it over the 3D anatomy. If you wish to see anything, tell me. Otherwise, I'll be leaving the volunteer and I'll be showing you on the 3D anatomy.
So all these blocks are in plane because they are very superficial.
All the blocks are in plane, and all these blocks are there in our YouTube channel. Please go to our Dorothea Pen Clinic YouTube channel and you can see all these blocks.
Okay, sir. Thank you so much.
All are in plane. None is by out of plane. Okay.
Sir,
So,
sir, one question on the foot, sir. Which are the commonest blocks we encounter, sir? Ankle and foot.
Commonest procedure we do.
Procedures, sir. Yes.
Two most common procedure. One is your plantar fascia injection, and second common injection is your retrocalcaneal bursa. These are the two most common pathologies which we normally do it. Few other things sometimes we do, but not that very common, is the tendinopathies of the tibialis anterior and the tibialis posterior. Sometimes we do the subtalar injection or tibiotalar injections. If you are going into the CIPS, WIPS syllabus, so only few things are there in the ankle. So two intraarticular injection, tibiotalar and the subtalar joint, and the tarsal tunnel tibialis posterior. These are the three things which are there in the, and the plantar fascia injection. These are the 2-3 things which are there in the CIPS exam syllabus. And these are the most common procedures.
Okay.
Okay. Okay. Okay, so just to show the difference, I'm just showing on the 3D anatomy about the okay, I was talking it. This is another condyle and coronoid, and this is your sphenopalatine, this the lateral pterygoid plate. So if I am removing that, sorry. So this fossa, let me remove all the arteries and the nerves. Okay, so this is the fossa. This is the fossa, pterygopalatine fossa or the sphenopalatine fossa. Everybody understood this pterygopalatine and sphenopalatine fossa? So this is the fossa. This is the fossa. So if we are going into the upper part, here is your maxillary nerve and here is your sphenopalatine ganglion. I'm just showing you again. If I'm putting the nerve, though the 3D anatomy is not that accurate, but still you can have some idea. I'm putting the nerves there. And so this ganglion is a sphenopalatine ganglion. You can see this ganglion is your pterygopalatine ganglion or sphenopalatine ganglion. This is basically hanging from this is your maxillary nerve. So this ganglion, so this is the fossa. This ganglion, if your needle comes into the, I'm just showing you the needle trajectory. So if your needle is coming like that, means this is your maxillary nerve block and this is your sphenoparietal ganglion block. But foramen ovale is completely different. Huh? Foramen ovale is if you have to look for the base of the skull. So here is your foramen ovale. Here. This was your foramen ovale. You see the difference? So if you are doing the maxillary nerve block, so sorry, let me clear the drawing. So this was the sphenoparietal triangular fossa through which we should be going the maxillary and the mandibular. The maxillary and the sphenoparietal. Posterior to that is your maxillary mandibular. And if we are going into the foramen ovale, so this was your foramen ovale. So here you can go for the, but this technique, standard technique is your CM guided technique. For sphenoparietal as well as the your foramen ovale is your CM guided. Okay, is it clear? Hello?
Yes, sir, clear.
Yes, so pterygopalatine fossa or sphenopalatine fossa is your target for the two procedure. One is maxillary and another is your pterygopalatine ganglion or sphenopalatine ganglion. And posterior to that bony plate, lateral pterygoid plate, you are having the mandibular. And if you are going little deeper, then we will be getting the foramen ovale. Okay, if you have any more question, you can ask me. Otherwise, Milton will be taking the pathologies and the interventions of the head and neck, of the face, sorry. Neck, so next class we'll be discussing. Okay, so Milton, please. I'm making you host, co-host.
Sir, am I audible and my
Yes,
slide
your
is
slides are visible and you are audible.
Okay. Thank you, sir. It was a nice class demonstrated by our respected sir. Actually, really great class. Now we are talking about the pathology as well as some intervention related to the neck head. Okay. So actually we have discussed about 6 nerve here, supraorbital, infraorbital, mental, maxillary mandibular, and the post auricotemplar. So most of the important part is the anatomy part that actually exclusively demonstrated and 3D anatomy already shown by sir. Because if you know the anatomy, then your intervention, also the pathology, and also everything is very easy. So I am not so much else of this anatomy, but very few things I want to actually share with you. Like the supraorbital, it is actually the pure sensory nerve, and it is the largest of the ophthalmic division. So many of the time actually we cannot do the V1 V1 injection like the alcohol neurolysis or phenol or something. So if that time is needed, the sensory block for the frontal region where actually the supraorbital nerve actually give the sensory supply, if needed you can give very easily, and it is very superficial. So here the frontal nerve enters through the orbital via the supraorbital fissure, and after that it just cross and in front, just it cross and in front the orbit and gives the two branches. Number one is the lateral side, that is the large branch, and another is the small branch, that is the medial side, the supratrochlear. But there is the notch that actually represent the supraorbital nerve, and it is the large branch. Okay. Now, so both supraorbital nerve also divided into the mainly the two part. Number one is the superficial, and number two is the deeper part. So superficial branch actually supply the sensory innervation to the medial forehead, upper eyelid, anterior margin of the scalp. And the deep lateral branch actually supply the cephalic direction and in between the glabionetrix and the pericranium to provide the sensory innervation to the frontal as well as parietal scalp of the vertex. So this is cover actually the huge area. So if there is any sensory pains, like there is if any neuralgia, or if many of the patient actually came with the neuralgia, as well as there is the allodynia or sometimes the hyperalgia, I cannot touch my hand over this area. If I just touch here, then I feel pain. If my fan is running, that time actually it causes the pain also, and I cannot actually tolerate these things. So this hyperalgesia and allodynia actually causes due to the nerve pathology, due to the nerve damage, sometimes the myelin damage, myelin sheath also damage. So what's actually correlate with these things? This is the supraorbital neuralgia number one. It may be either by the nerve itself damage by direct trauma, or sometimes there is a tight, many of the swimmers actually wearing a glass and tight, very tight glass. At that time, it actually also causes there is the compression over the supraorbital nerve, and that causes the swimmers headaches. So it causes the actually entrap the nerve from the outside pressure. And sometimes if there is any trauma, there is any tumor or any mass or lesion there, it causes also the supraorbital entrapment. And another one thing that is the herpes zoster, because herpes zoster is common in the um, upper thoracic region as well as the facial region also. Many of the time actually it involves the V1, V2 and V3 trigeminal nerve also, so distribution area. So it's many of the time V1 area also involved by the herpes zoster also. Okay. So now, so these few things actually clinically we find, like the supraorbital neuralgia, sometimes the entrapment, sometimes there is the headache when actually the swimmers wearing the very tight glass, and many of the time there is the herpes zoster involvement into the V1 division of the trigeminal nerve. And actually ultrasonograph technique already sir shown these things. Actually we patient is in prone position, and it is approximately from the midline to 2.8 centimeter lateral, and just place your probe very gently over the frontal bone, and just come down and just come to the supraorbital notch, and you find a bridge. Actually, these bridge two important things. Number one is the artery, and another is the nerve. So it contains the two things. Number one is the artery, and another is the nerve. So we can find out the nerve by guiding the artery. So we should use the color Doppler. So number one is the bony breakdown you find. Number two is the Doppler. It showed the color. many of the time you are so much compressed or tightly adherent of the probe over the skin, it may sometimes collapse. So it should just hanging or just touch over the supraorbital area. So after the finding of these things, you should just compare in between the right and left side. So if there is any abnormality like this, there is any mass, or if there is any other structure, if you find that, you can mention and you can just treat accordingly. If there is no change, so you can that time first you can do the diagnostic block. So if the patient is improved, then you can do the intervention, and you can do like DEXA or depo-steroid intervention, as well as you can, if you after doing a successful diagnostic block, you can also doing the radio frequency also here. So it is a sensory, so you can do the conventional radio frequency also here. um, mm, and you can do also the cryo. Most probably in our Dorodia center also did cryo here. I saw it in the Facebook. So you can also do the cryo, but you can do these three things. Okay. And very important part, during the intervention, you should not touch the blood vessels, because this is the blood vessels actually gives the supply a important part. If you are just piercing the artery, try to don't pierce this. If you are piercing this artery, so that time, many of the time actually it distal supply may be hampered. Even face is the highly vascular area, so it has a lot of collateral circulation, but should be try to avoid to injury the blood vessels. Okay. And another very important things, though it is a very superficial structure, so you can use the gel standoff technique. So your needle is so nicely visible with the in-plane technique, and you can very fine identify. So here we show the both of the technique, in plane and out of plane, but better to try in plane, and you can also take help of the gel standoff technique, where this is the bony area. So gel standoff technique means it is the probe. So one part of the probe touching the that's mean the body surface, and another part that is actually hanging like area. So in between, it should not there the air, so it should be covered, or it should be filled up by the gel. Okay, so this is called the gel stand off technique. So one part is stand over the gel, and another part just touching the body. So your needle should be from here to this part. So the second, that is the infraorbital neuralgia, and the other disease like just that causes the infraorbital. So infraorbital, it is also the pure sensory, and it arises and from the maxillary nerve. So if there is it is the sensory part. So you can just touching in between two things. If there is any the touch and the crude touch and the fine touch is just there is the changes. So and patients sometimes there is the numbness, and there is the some tingling sensation, some painful sensation, even some allodynia, or many of the time the hyperalgesia is there. So with this complaint, actually patient come in our center. So here is the very little bit of the anatomy, like these actually nerve enter the orbit via the infraorbital fissure. After that, infraorbital nerve passes along the floor of the orbit into the intraorbital groove along with the infraorbital artery. With the infraorbital nerve, it exits the infraorbital foramen. So here also there is the bridge, number one, bony bridge. Number two, there is the one is the artery and another is the nerve. So here we actually guide by the artery when actually we use the Doppler. Okay, and after that, actually here is divided some division. The mostly the superior alveolar branch, it actually give a lot of area sensory supply, like there is the upper incisor teeth, canine teeth, and also the gingiva and the cutaneous branch that actually fans out the sensory innervation of the lower eyelid and the lateral nares and the upper lip. So this area here actually shown in this area actually supply by the alveolar branch, and some other branch actually very small branch, and actually it may divided multiple in branches. Okay, so but the root actually exit through the infraorbital uh, infraorbital foramen. So our target is infraorbital foramen. And here also the same things. There is the like the road traffic accident. Sometimes it be due to the entrapment by the mud or by the tumor, or sometimes there if there is arterial any problem, like there is the um, aneurysm or there is the formation is there. Sometimes there is the problem or the sensory area. This sensory area actually is the problem, like the touch is changes. There is hyperalgesia. Sometimes there is the allodynia may be present. So here is the same things. Actually, the just below the eye hit. Okay, so here actually we found from middle to here it is around 5 to 2.8 centimeter from the midline. Okay, so actually the identify the interorbital foramen by the placing of the transducer in the sagittal plane in just lateral to the nasal crease and scanned laterally till the hypoechoic break the bony identification. Okay, so after identification, the discontinuity or is the bridging of the bone, then you give Doppler. And you there is the also some things you should not press your probe very tightly. Better to it's just touching gently. Okay, because there is a very superficial artery. So if you are giving the over pressure over these area, it collapses the blood circulation. And here is the also very important part, that is the it actually the main blood vessels of this area. So during the intervention, it should not actually hitting, it should not actually piercing the blood vessels. If you are piercing the blood vessels, it sometimes just spasm, and many of the times it actually bleeding inside there. So better to give a small amount of the local anesthesia, so it the blood you can very nicely identify the blood vessels, as well as just the side of the blood vessels there is the nerve. So you can give there either you can give the deposteroid, or you can give the dexamethasone, or after doing the successful diagnostic block if needed, and if the persistent pain, then you can plan for the radio frequency, because it is a pure sensory. So you can do the conventional radio frequency also. So third one is about the mandibular neuralgia. So the same things are already shown very nicely. So the it is actually the sensory branch of the mandibular nerve, and it actually along with mental branch of inferior alveolar artery. Actually, there is the inferior alveolar artery. So along with the, it actually exits through the mental foramen, just the second premolar teeth. So here you can see, just if you hold your probe over here, just you can see that there is the breathing and there is the arterial pulsation, and just side of the arterial pulsation there is the nerve, and it may actually like if there is the traffic accident there is the direct trauma, if there is the any tide something, it causes the actually the entrapment of the nerve and causes the just the outside of the body. If there is the huge actually entrapment of the some things, it causes the entrapment. So if there is any tumor or some things under your ultrasound, you should compare with the other normal site. So though it is the sensory, so there is the changes of the touch, so there is the tingling sensation, there is the numbness, so there is some sort of the hyperalgesia or allodynia. So if you are find this thing, so you can plan for the this nerve block. Okay, so here we can see these things. There's some clinical correlation, like there's a tight facial bandage. If there is some bandage in here with very tight, so the tumor is there. So sometimes the especially when actually we are during the anesthesia, sometimes the general anesthesia we are masks and back ventilation. If we are giving the very tight over this area, it sometimes causes the mental nerve compression from outside, but it is not the persistence. But if it is for the long time, and if the nerve is injured by the outside pressure, it causes the chronic pain. So another is the numb cheek symptoms also. If there is the another is like the herpes zoster is involved to this area, it causes the pain and numbness. So you can block this mental nerve for this cause. And sometimes if there is any cellulitis or any abscess, so it very superficial, and sometimes it actually involve the nerve also. So sometimes the just subcutaneous tissue are so hard, so actually fibrotic, so it causes the adherent, or it causes the actually fibrosed the nerve area. So you can also identify if there is any changes over this area, there is the history of the cellulitis or if history of the abscess in there, so it also causes the entrapment or the nerve fibrosis in this area. So the technique is this also the same. It is almost the 2.5 to 2.8 centimeter lateral to the midline, and it is just correspond to the second premolar teeth. And to identify the mental foramen, the transducer is placed transversely over the inferior part of the mandible at the level of the second premolar and scan the cephalic direction, and until the hypoepic break identification, the foramen is found. So after find this foramen, here we can see there is the break. So after found this foramen, you can see there is the arterial pulsation that show when you give the Doppler. So here you can identify these things, and there is the just side of this, there is the nerve. So here is the also the same things, better to just avoid to injury the blood vessels, because there is the very important blood vessels to give this area supply this area, so better to avoid these things. Okay, so the same things here, and you can give the in-plane like these things with the help of the gel standoff technique. You can go also for the out of plane, but better to give the in-plane, and in-plane is very technique. And you can also if you have the hockey stick ultrasound probe, so that is so light, and you can handle this probe very gently, because it is a very superficial, as well as there is the curvature is there. So if hockey stick probe is there, that is better for intervention. Okay, now we go for the auricular temporal neuralgia and other disease. So auricular temporal the auriculotemporal nerve is a branch of the mandibular nerve, and which is the third division of the trigeminal nerve, and its fiber leave the mandibular nerve to enter the parotid gland. Parotid gland just posterior to the uh, temporomandibular joint. So our probe position is also the same area, just posterior to the temporomandibular joint. So when you just hold your probe just posterior to this area, so you can see very nicely there's the arterial pulsation, and just correspond with the arterial pulsation, that is the auricular temporal nerve. So here the actually nerve travels cranially, passes between the temporomandibular joint and external auditory meatus. Okay, so here we can see there is the external auditory meatus. There is the this is the nerve actually accompanied with the blood vessels. You can see the blood vessels, so accompanied just posterior to the temporomandibular joint, and the in between the post and the external auditory meatus. So here actually gives the sensory supply to the temporomandibular joint. So many of the time actually patient come with the temporomandibular dysfunction, or sometimes there is the pain. Even sometimes the rheumatoid arthritis patient also come with the temporomandibular joint pain. So many of the time actually we give the temporomandibular joint injection, but here is important part is the auricular temporal. So if there is the sensory problem, like the hypoesthesia or paresthesia, or the hyperalgesia or allodynia around the temporomandibular joint area and part of the pinna, so that time actually you can give these nerve block, and also you can identify the problem by giving the diagnostic block also. Okay, the same things. Okay, so what are the clinical actually problem may there is the aberrant blood vessels, especially the like the superficial temporal arteries. If there is the aberrant blood vessels, so sometimes it causes the like the compression. If the parotid tumor or cyst, so it causes also the compression over this nerve. Okay, so the neural tumor have also causes of the variety of the painful consideration, including the post-traumatic auriculotemporal neuralgia also may be there. The fairy symptom is there. The gasturi sweating symptom is there. The Hamseris Horn symptom is there, and temporomandibular joint dysfunction, and sometimes there is the cancer that arises many of the time from the parotid gland. So these actually problem may there if it was diagnosed by the other physician, like there is the Hamsari Hunt symptoms by the like the medicine department. But if there is the persistent and the sensory problem and the some paresthesia, so you can do the diagnostic block, either it is injury or either it is causes the symptom or not. So you can do the diagnostic block. After that, you can do the radio frequency for this area also. So the auricular temporal nerve is frequently damaged during the surgery of the temporomandibular joint and the parotid gland. So if there is the parotid gland, so sometimes like the injury. So if it is injury, so it causes the neuralgia or the long time the neuropathic symptoms also. So so also there is sometimes if there's the temporal craniotomy or the some plastic surgery, facial plastic surgery, also it causes the damage this nerve. So if this is damage, so you can actually identify by the diagnostic block. After the diagnostic block, you can give the dexa or deposteroid. After that, if you plan for the long term treatment, so you can plan for the like the that's mean radio frequency you can do for these things. Now, so ultrasonography technique. So we actually first identify the zygoma and the temporomandibular joint. Just palpate and just over it you put your ultrasonography probe. After that, you turn it into the posterior side. You can identify there is the arterial pulsation, temporal arterial pulsation. So here actually just posterior to the arterial pulsation, there is the nerve. So we can see this is the nerve. So we can see this is the arterial pulsation. So here is we can see the auriculotemporal nerve is there. So you can give injection in plane and out of plane, both of the both of area. Okay. So now actually the mandibular nerve block. So mandibular nerve block, so already sir shown through the anatomy. So we can see how can actually identify the mandibular nerve. So a very important as well as the very short anatomy because the mandibular nerve is the third division of the trigeminal nerve, and it arises from the trigeminal ganglia and which lies within the cranium and close to the anterior surface of the petrous part of the temporal bone. After that, actually it crosses and it comes to the facial area. So very small part of the trigeminal ganglia I want to discuss with you. Actually trigeminal ganglia, it is called the trigeminal. So there is the three branches. So the first one, that is the ophthalmic, so it lies in the middle side. So after that, there is the maxillary, that is V2, that is lies in the middle, and the V3, that is lies in the ventrolateral, that's mean the lateral part of this area. And actually the both motor root of the mandibular nerve runs anterior and the medial to the sensory root and passes inferior of the ganglia, and after come to this and it cross the foramen ovale and comes to the part, and after that it gives the sensory to the mandibular nerve area, distribution nerve area, and also gives the motor. There is the motor distribution also, but there is the very important is the sensory part is give this area. So actually this mandibular nerve gives a huge area. Innervation area is the lower face cheek, the lower lip, the anterior part of the external ear, and the part of the external acoustic meatus, and the anterior 1/3 of the tongue, and teeth, especially the lower jaw, ipsilateral, because that there is the two nerves. So the ipsilateral side is the and also the mastoid air cell also supply it. Okay, and there is the very important some muscle we actually there is the temporalis masseter muscle, external and internal pterygoid vaccinator muscle, and myohyoid and tensor palatini, and the tensor tympani muscle also supply by this mandibular branch. Okay, so here actually indication if there is the idiopathic trigeminal neuralgia affected the mandibular branch of the trigeminal nerve. If there is any secondary mandibular neuralgia, like there is the cancer, so it causes the secondary cause, so it causes the continuous irritation of the mandibular nerve, so it causes the mandibular neuralgia. And there is the compression of the mandibular neuropathy from miscellaneous, like there is the blood vessels, aberrant blood vessels, so it causes the outside pressure over the nerve area and causes the pain. Okay, so here actually how can we identify the this area? So here we can see this is the actually over actually we put our ultrasound over this area. So this is area, so actually this is the arch of the zygomatic arch. So the posterior part actually it formed the uh, TM joints. Okay, so these actually area is called the condyle, and the anterior part that is free, this is called the coronoid. So over this area we actually just put our ultrasound. After that it comes anteriorly, so we can see the deeper structure where there we can see the superficially we can see the masseter muscle, and this is the coronoid. So here we can see the coronoid, and after that there is the open space, this is called the this is the another window, so we can see the deeper structure, that is the lateral plate of the pterygoid process. So here we can see these actually arterial pulsation. Here we can see the arterial deep, very important part. This is not the superficial, this is the deep area. So there is the coronoid. After the coronoid there is the bridge, so you can see there is the deep blood flow here. We can see the blood flow here at Doppler here. So this area we can actually insert our needle from here to this area. Okay, so anteriorly, so this is the anterior part. Here we can see this is the anterior of this area, and this is the posterior part. So the posterior part, this is for the mandibular, but here the anterior part, this is for the maxillary. So we can insert our needle from here or by the head. So you can give from the superior part of the this arch, and also the just you can give also the hair. Okay, so here we can see this is the out of plane injection. So here you need just when in case of the out of plane, so when you just insert your needle, so you should just try to see your needle tip. But this is the here is very crucial part. This is the probe, and this is your outside uh, like needle insertion. So you can see through here the shaft, not the tip. So here is very important part is the angle. So how much angle actually we are doing? So actually we are doing around 15 to 20 degree, and better to insert 1 centimeter from the probe, 1 centimeter away from the probe. So it 1 centimeter away from the probe, and try to less than 20 degree, it's around 15 degree, sometimes more. So just try to see the tip of the needle. So how can you identify the tip? Because when you enter your needle, just there's some jerking movement, so the tissue just in front tip of the needle, there's a jerking of the tissue, but in the shaft there is not jerking. So if you can see your needle shaft is there, but jerking is there. So you have crossed the ultrasonography beam like this. So you can see the shift like the shaft of the needle, but you cannot see the needle tip. So better to withdraw and decrease your angulation of the needle. So that time you can see the needle tip. So better to start your in plane in any of the cases. After that you do the out of plane, but here we need to the out of plane. So better to do after giving some injection out of plane. So it gives the guide how to actually visualize your needle tip in out of plane. So but so far you can do this kind of intervention very easily. Okay. Now the maxillary, sorry, actually this is the mandible. Sorry for some actually disorientation of my slide. So actually first we demonstration this needle insertion, that is for the actually the mandibular insertion. So now that is the actually for the maxillary maxilla. Okay. So here we actually maxillary actually entrance through the foramen rotundum. So after comes it innervate the maxillary sinus teeth and the upper jaw, and after it the ipsilateral the face and the nose and the upper lip and the mucosa of the lower eyelid of the upper lip and the hard and the soft palate and the nasal cavity, pharynx and the other like the dura mater of the middle cranial fossa. So here is the same things that sometimes there is the idiopathic condition may there, or the sometimes there is a secondary like the cancer or anything, it causes the actually compression of these things. So here we can see the maxillary artery when actually see the maxillary artery, because this is the here we can see this is the mandibular branch, and actually the ultrasonography picture actually just doing opposite. So this is the maxilla. So maxilla lies the anteriorly, and the mandible it's when actually you giving these things, this is the actually the posterior part. So how can we identify these things? So first time we need to the see the pterygomandibular space. So we need to the pterygomandibular space to see this thing. So pterygomandibular space, how can we see? So we should actually probe over the over the arch and see touching the two. One is the condyle, another is the coronoid. So you can see the very narrow space. Actually, there is the bony land, bony echogenic structure. You can see this is actually the arch. After that, when actually patient open the mouth, you can see the deeper structure. This deeper structure actually, there is the this is the nerve and there is the blood vessel. So this nerve actually lies over the pterygomandibular space. So this mandibular space actually you can see the arterial, very good arterial pulsation. So here actually just cross the masseter muscle, it is not so deep, it is the superficial. So cross the masseter muscle and just side of the arterial pulsation, you can give your injection for the mandibular branch injection. So sorry for actually ultrasonography page is actually just disoriented. Sorry for this. So just few things I will just try to repeat. One is the, so anteriorly that is the maxilla and the posteriorly that is the mandibular. Okay, so during the mandibular we need to hold our probe just condyle and the coronoid, over the condyle and the coronoid, so you can see both of things. And after that we need to open the mouth, so that time we can see the pterygomandibular space. So after cross this muscle, this space actually for the intervention, this is for the mandibular intervention, mandibular nerve block. Okay, and here maxillary. So how can we identify these things? It should not over the condyle and the coronoid, it should become some of the anteriorly. So after come to the anteriorly, we can touch over the coronoid. So this is the posterior part, this is the pterygomandibular arch and pterygomandibular area, and this is the part where actually we can see the deep structure, that is actually the pterygoid process. So here we should give the Doppler and we can see there is the arterial pulsation, just very deep structure. So we can give our needle through it and just give side of the just side of the arterial pulsation. So we can give these things. Okay, so so we can give block by these things. But if you need to the main, that's mean the trigeminal block, so it should be go under the CM, because the standard is the CM. So never go for the under ultrasound. If you want to give the peripheral side like the maxillary or mandibular nerve sensory block, so you can give the peripheral block like this over this area. So thank you for patience here, and also sorry for some disorientation of my slide, sorry.
Okay, thank you, Milton. Overall, it was a nice presentation, and I hope everybody has enjoyed it. And
Sir?
regarding the maxillary and mandibular, we already told you, better is your, always safer is your to go in the in-plane technique. And you have to find out the mandibular notch between the coronoid and the condyle. And you have to identify the pterygoid plate. Anterior to the pterygoid plate is your maxillary, posterior to the pterygoid plate is the mandibular. So this is very simple things to remember. And open your mouth so that your space is increasing, so that your needle can be visible, and always take the ultrasound needle so that your needle will be visible. Okay, somebody was asking some question.
Sir, in our place, the oral cancer is very common, and it is very common to do hemimandibulectomies. And there are many patients who come with pain from the top of the head, side of the face, neck, and up to the shoulder. Their anatomy is totally distorted. So, what is the simplest thing we can do for these patients?
In this situation, the simplest thing is your stellate ganglion block, because that will be covering the, because most of the cancer pain, the sympathetic block has a very important role, and there you can go for that. But again, the cancer pain, first pharmacotherapy, your, all these things should be tried. The role of the nerve blocks are there when the nerve is pain is basically limited to one or two of the nerves. If whole of the area, you can, many of the area, like what you told right now, you can try the stellate ganglion block if it is sympathetically mediated pain. Many of the head and neck pain in cancer patients are mediated through the sympathetic fibers. So you can try that one. If it is not effective, then in this wide area of the pain, I don't feel there is any interventions possible. If interventions are possible, if after hemimandibulectomy or maxillectomy, sometimes this patient are having the pain in particular area of the trigeminal nerve distribution, then you can think, in fact, I have done few of the cases and also I have some of the journal publications on this, that we can go ahead with the Gasserian ganglion block. Gasserian ganglion block again, because in these patients, bony landmark are not there, it is very difficult to do under the ultrasound guidance. So here, the advisable is CRM guidance, and you just identify the foramen oval in the base of the skull, and you go ahead there and you do the procedure there. Procedure means it is always advisable to go for the radiofrequency procedure in these situations. So few of the cases I have done, and it gives very good results. But otherwise, simpler thing is to go ahead with the steroid ganglion block. Steroid ganglion block, next day we'll be covering the steroid ganglion block in the neck. So that can be timed.
Thank you,
Okay.
sir. Yes,
Okay.
sir.
Any other questions? Otherwise, we'll be wrapping up today. Next day is your cervical areas, neck, anterior and the posterior neck, and then your thorax. And by mistake, we have forgot to mention the abdomen, but it's not abdomen, it is the lumbar area. So thoracic and the lumbar area will be the last class. And after that, exam link will be open, and you can take your exam after this next two modules. In fact, after the 2 weeks, exam link will be open. And also the lectures, this Zoom lectures will be available till the end of your course. Means after the 12th module, another 2 weeks, you will be having the time for the exam. And for that 2 weeks, you can access all the recorded lectures also.
Okay, sir.
So thank you very much and good night.
Good night, sir.
Good night.